Welcome, everyone. This is a fantastic group. We're very excited. Welcome to the Center for Excellence in Disabilities at WVU's Ability Grand Rounds. This is our May presentation, and as many of you are aware, today is Election Day in West Virginia, and that's a day that highlights the importance, obviously, of civic engagement and policies that shape our healthcare, social service, and justice systems. These decisions influence access to care, disability supports, aging services, and the well-being of vulnerable populations across our communities. One population that is often overlooked is in these conversations is aging individuals with disabilities within correctional settings. So, as healthcare professionals, it is important that we understand that unique clinical, ethical, and systems level challenges affecting these individuals, particularly as the population of older adults in correctional systems continues to grow. So, because of today's Election Day activities and schedules, we are using a slightly different format. I'm going to present or introduce our speaker, and we will still have time for questions at the end. We might have some particular topics that generate some additional discussion given the Election Day focus. Just a few reminders, because we're on Zoom, we encourage discussion throughout this setting. So if you are comfortable doing so, please come off your camera or turn on your camera. We love to see you. We understand if you don't feel comfortable. We're all home in different settings today, and so that is quite all right. If you can, put your name and affiliation in the chat. And then a few housekeeping pieces. If you need a certificate of attendance, let me know. But at any time, please put out questions, thought-provoking comments, and I'll be monitoring the chat while our speaker is going through her slides. So, having said that, I want to ask you to help me introduce Dr. Kate Miller. Dr. Miller is an assistant professor in the Department of Health Policy, as you can see here with her slide, and management at Johns Hopkins University. And with that, Dr. Miller, I'm going to turn it over to you.
Wonderful. Thank you so much. And thank you so much for the opportunity to be here today. As Dr. Cottrell just mentioned, I'm an assistant professor in HPM at Johns Hopkins. I'm also an investigator in the VA as well, but I want to be very explicit that I'm representing myself only today, and I'm not here in any VA capacity. And today I'm going to talk to you all about a project that I've been working on focused on aging, disability, and incarceration, really focusing on how we calculate prevalence estimates, what the policy implications are from what we do know, and all the opportunities for future research priorities. The work I'm presenting here today was unfunded, but I want to acknowledge, of course, my current funders. I have no conflicts of interest to disclose. And again, the materials presented here solely represent my own views and do not represent the view of any institution with which I am affiliated. To guide our time together today, I put together some of our objectives, really focusing in on the prevalence and types of disabilities observed among older adults in correctional settings, talking about the policy implications and, of course, opportunities for future research to identify the gaps in the existing evidence space so that we can push the science forward. I also want to level set from the beginning that throughout my presentation today, I'm not really speaking or tackling to some of the more philosophical questions that are relevant to this research. For example, what does it mean to incarcerate somebody who has severe cognitive issues such as Alzheimer's disease and related dementia? Those are really important and sensitive questions that I would just defer to my colleagues who are bioethicists as more appropriate to tackle those questions. And so what I'm really focusing on today's conversation is the current situation at hand, what we know, what we don't know, what are potential policy levers that we can pull to address any care needs that we observe currently. So I'm going to give some background, some introduction about why I think this topic matters, go through our methods and results and from some recent work, and then discuss the policy implications and the numerous gaps in the evidence and the opportunities for future research. So before we jump in, I also just want to acknowledge that oftentimes when we talk about aging and disability related research, we either focus on individuals with disabilities ages 18 to 64 or like under 18 or 65 and above. And when we talk about aging related disability, it's really focused on individuals who are age 65 and above. But when we're conducting research on older adults in correctional settings, we actually often use a threshold of 55 or older to define older adulthood. Some folks will use 50 or above, so there is some variation there. I'm going to use the threshold of 55 or above. And the reason why we do this is because it reflects the accelerated aging that might be associated with incarceration, exposure to more chronic diseases and long sentences, and this kind of underlying concept that people in prison may experience age-related limitations earlier in their life course than their peers in the community. And so, with that said, I want to note that the prison population in the United States, much like the civilian population, is aging, right? And the number of people in prison who are 55 and older grew by about 280% from 1999 to 2016, which is particularly striking when we consider that the population who's incarcerated under age 55 increased by just 3% for the same time period. I'll also note that as of 2020, about one third of people who had life sentences were age 55 or older. And we see this trend occurring not only because the civilian population is aging, but really because of the changes with punitive sentencing, like mandatory minimum sentences and three-strike laws that became really more commonplace from the 1970s to 2009. Excuse me, the 1970s and 1980s, and the rate of incarceration more than quadrupled largely as a function of these policy changes between 1970 and 2009. And when we think about why we should consider the needs of older adults in prison in particular, it's important to remember that prison environments are not really designed for aging populations or to support individuals with intense care needs. And so we can think about this in a couple of different ways. We can think about it with regards to the built environment. For example, the use of bunk beds might be particularly challenging for people with different types of functional limitations, disabilities related to, say, like hearing loss or cognitive difficulties can be particularly challenging when we think about day-to-day activities and how activities are structured. For example, it's very important to listen to directions about where to go and at what time. And if you have hearing loss or cognitive difficulty, it might be particularly difficult to function in this kind of environment. And so in these multifaceted ways, beyond just the built environment, the carceral system can be particularly challenging for people with disabilities. And then we know that community dwelling older adults often face challenges in accessing care services that they need in order to remain living independently. And those challenges are well documented in the literature, so I won't belabor them. But when we consider the unique challenges facing incarcerated older populations, we have not just like traditional challenges, like is there a workforce available to provide care, but there are additional issues as well. It really puts stress on the carceral system because the carceral system was never designed with the intention of providing long-term care. And so some estimates suggest that it's about twice as expensive to care for an older adult compared to a younger adult in prison. And the built environment and these available resources are often misaligned with the needs resulting from age-related disability. And I think this really highlights how vulnerable this population is. And I think that that was made even more evident during the COVID-19 pandemic. We all saw a lot of nursing home press, a lot of press on the experiences of nursing homes and the high mortality rates during the COVID-19 pandemic, as there absolutely should have been a lot of focus. That was a terrible situation, of course. The rates of death in prisons were also very high and, in fact, surpassed deaths in nursing homes at certain points. And this was another very vulnerable population. And I think that this really highlights collectively the incongruence of having a carceral system administer long-term care services to this vulnerable population who can benefit from supports. And so I think it's important to note that when we think about the implications of having an aging incarcerated population, it's not just affecting the individual. There are also broader public health system level consequences. When individuals are aging, this has implications for how facilities set up their staffing, space, budget, and medical service needs, how they conduct community placement and long-term planning. And there are a lot of examples to pull from. For example, there's a facility in Massachusetts that actually opened an entire unit based on the nursing home model in order to serve individuals with dementia, with an interdisciplinary team, employing use of de-escalation techniques. And we've seen that other states have also started hospice programs, crisis intervention training for people with dementia. Some states have also developed programs to specifically support incarcerated persons with dementia using peer support programs where they basically pair somebody who has dementia or cognitive decline with a companion in the facility. And these two graphs here just give examples of data that's actually quite old. This is from 2004. And what we see on the left is the percent of facilities that states using other inmates as caregivers for people with cognitive and functional limitations. And you can see that 53.1% of states acknowledge having at least one facility that did so. And I think that stands in really sharp contrast to data from the same year, where they identified only 18.4% using community volunteers as caregivers. And this raises a lot of really important ethical questions, I think, about the quality of care that's being received, what is the care recipient entitled to, and how is the individual who's a fellow incarcerated adult, how are they being incentivized to participate in such a program? And I think that these innovations that facilities are implementing are really creative and obviously, designed to meet a need. But I think, again, this really underscores how carceral systems as currently established are not intended to or really funded to provide comprehensive long-term care. I mean, converting an entire unit into a nursing home is a very expensive undertaking. Similarly, this is data from the same report that was published in 2004 from the Department of Justice National Institute on Corrections that shows the number of states reporting their hospice unit structures across facilities. And you can see that 25 reported having an independent hospice unit, 22 said that it was part of an infirmary, 8 used an outpatient program, 5 had an entirely separate unit, and 4 made it part of a housing unit. So there's a lot of variation here. And one of the things that I found particularly striking when I first started doing this research and reading all this background information was that we don't have a lot of information about the effectiveness of these different programs. What we do know really comes from investigative journalism, small or qualitative studies that have limited generalizability. And one of the only really few national large-scale surveys that we can leverage comes from the Survey of Prison Inmates from the Bureau of Justice Statistics. And this is a really interesting survey, but it does include challenges. For example, it's conducted at irregular intervals. The last time, to the best of my knowledge, that it was fielded was 2016. And a lot of the health questions that they ask about are heavily slanted towards substance use and mental health disorders, which makes a lot of sense given the overwhelming needs of the incarcerated population. But as the population is aging, I do think there are opportunities to expand upon the questions that are asked to capture some greater nuances about disability and functional care needs. So all this to say, in general, this topic is really understudied. There are a lot of gaps in the literature, and I'm going to mention a few of them kind of as we walk through the slides today and then summarize them at the very end. And I think there's a lot of room and a lot of opportunity to do more work here, especially from a broader, national perspective. So to begin to try and address some of these gaps, my colleagues and I used survey data that's nationally representative to try and strengthen our understanding about the prevalence of disability among older adults. who are incarcerated and looking at it over time, both prior to and immediately after the COVID-19 pandemic. We believe that this is really foundational information in order to help inform evidence-based planning and policy. So I'm also going to describe the prevalence and disability of older adults in prison, as well as community dwelling adults 55 and older. I want to be very clear that I'm not intending to make like counterfactual comparisons, but rather to provide context about community dwelling peers when we think about how to interpret and how to think about the rates of disability on average and over time for the incarcerated population. So we use the American Community Survey, which is nationally representative. It's a repeated cross-sectional, and we use survey data from 2008 to 2019, and then 2021 to 2022. We exclude year 2020 because data collection efforts were really quite disrupted during the COVID-19 pandemic. And the construction of the survey weights in order to make the data nationally representative are really considered experimental. And so we focused in on identifying two key parts of our sample, right? Our community dwelling adults, age 55 and older. And then from the survey, we're also able to identify adults who are living in group quarters. And so we identified 13,877,665 community dwelling adults. And for our adults in prison, we ended up identifying a little under 33,000. But identifying the adults who were likely imprisoned was actually quite complicated because we only see if they're living in group quarters. And so that group is comprised of two subgroups, people in nursing homes and people who are likely in prisons. But the publicly available ACS does not distinguish between those two types of institutional residents. And so what we did is we had to leverage variation in regulations that exclude individuals in prison from receiving certain types of federal benefits in order to delineate who's likely in a nursing home and who is likely incarcerated. And so the policies that we exploit are largely based on eligible sources of income and health insurance. So, for example, people who are ages 55 to 64 and are residing in these institutional settings without any form of health insurance and not receiving Social Security or supplemental security income, we identified them as likely incarcerated as opposed to being in a nursing home. And then for individuals 65 and above residing in institutional settings without Medicare and not receiving Social Security or supplemental security income is how we identified people 65 and older who are likely in prison instead of a nursing home. Because we know that if you're in a nursing home and you're 65 and above, you probably have Medicare, and a fair share will also have Medicaid. And so this algorithm that we constructed is deliberatively conservative. We wanted to err on the side of caution of potentially underestimating the number of people who are likely incarcerated. But there might, of course, be measurement error, and that's really important to acknowledge. And we did a lot of checks in order to try to validate this to make sure that we've correctly identified and separated out the two groups, which I'll talk a little bit about in a few slides. Okay, so we considered 4 primary measures of disability. Specifically, we examine if a respondent has any cognitive difficulty, any difficulty with ambulation, any difficulty with independent living, and any difficulty with self-care. All of these measures are asked as yes/no questions. These are 4 measures out of a total of 6 that are used to estimate national disability prevalences as reported by the US Census Bureau. So they are used for policy evaluation purposes. They're also asked in the survey of prison inmates by the Bureau of Justice Statistics. And I want to be totally upfront, and I'll be the first person to acknowledge that these questions lack a lot of nuance in how we would like to measure disability. Unfortunately, this is the data that was available to us, and given how they are used by other policymakers, we decided to proceed with them. But in the future, I think we would all be much more enthusiastic about a more nuanced and granular definition of disability. So in this repeated cross-sectional study, we're first going to estimate the number of adults age 55 and older who we identify as being likely imprisoned in our algorithm and compare them to the data from Correctional Statistical Analysis tool, which is put forth by the Bureau of Justice Statistics. And you can calculate the number of people in a given year based on an age cutoff. And then to further quantify the comparability of our estimates to those numbers, I calculate the average percent difference between our estimates and the CSTAT, which we are treating as, say, the truth. And then we pool all the years of data so that we can calculate the average percent of people experiencing any disability, describe the demographic characteristics of our sample. Again, for context, I provide the same of everything about our community dwelling adults age 55 and older. And then finally, we use logistic regressions to examine the association of being incarcerated versus not on each of the four outcomes of interest, adjusting for age, sex, race, education level, marital status, year, and census region. So I'm going to present the average predicted probability, 95% confidence intervals. All analyses include survey weights to yield corrected standard errors, nationally representative estimates, and we calculate the differential association of being in prison versus community dwelling using the method of recycled predictions as aligned with best practices. So going ahead and jumping into our results. So this figure here shows the estimated number of adults age 55 and older in prison from 2008 to 2022. And so you can see here in black, the black line, these are our estimates from the American Community Survey. And then the gray line, you can see these are the estimates that come from the Correctional Statistical Analysis tool from the Department of Justice. And so you can see that they're actually quite similar. The Correctional Statistical Analysis tool at the time of this project only went through 2021, and that's why we don't have that last year of data there. And when we calculate the percent difference from our estimates and the reported numbers from the CSAT, we get about 3% difference. So they are quite close. We also examined to further have confidence that we've identified the correct population. We calculated the prevalence of adults in prison per capita at the state level, and then looked and see how that correlated with the states that we identified as having the most number of adults age 55 plus incarcerated per capita. And so we observed 7 out of the 10 states with the highest prevalences of imprisonment per capita in 2019, that they also have the highest prevalences of imprisonment among adults 55 and older in our sample. And so as you can see here, the estimated number of adults in prison is growing over time. What we find is that from 2008, the population grows from a little under 103,000 to about 172,000 in 2022. This is a 67% increase. The estimated, excuse me, and then as I mentioned, this is about 3% difference on average from the CSTAT. And so here, I want to just spend a moment and note the demographic characteristics between our sample of likely imprisoned older adults and our community dwelling older adults. We see that the likely imprisoned group, as we might expect, given what we know about the incarcerated population, they are much more likely to be men. They are more likely to be Black or African American, or American Indian or Alaskan Native, Chinese, Japanese, other Asian, 2 or more races or other. They're also more likely to be Hispanic ethnicity. And then we also did a check. So there is a marital status variable in the data set that allows you to identify whether or not the spouse is present or not. And among our likely imprisoned adults, we see that 0% have a spouse present, which is what we would expect if our algorithm has correctly identified this population. We also see that our likely imprisoned older adults are more likely to have less than a high school level of education. And we also see that they are concentrated in the South, which tracks with where we observe the highest prevalence of incarcerated populations more broadly. I mentioned before that we can't precisely identify, right, our incarcerated population from our nursing home population. We don't know as much about the incarcerated population. Hopefully, what I've shown you thus far convinces you that we've done a good job in identifying our incarcerated population. But we can also tackle that question from the flip side, which is we know a lot about the nursing home population. So, can we check and see if our algorithm is identifying um, the number of nursing home residents that we would expect? And so what we did here is we mapped out the number of nursing home residents that we identify in our algorithm in the black line, excuse me, in the gray line up here. And then in the black line here, this is the number of nursing home residents that's actually reported by the American Community Survey. Even though they don't make that data publicly available at the micro level, they do provide this aggregated data. And so what we see is that in 2019, the ACS reports basically 1.4 million nursing home residents, and we identify about 1.5 million. So, as we expected, our approach is potentially undercounting the number of people who are likely imprisoned and therefore overcounting the number of people likely in a nursing home. We did look at the demographics for this population, and it's very closely aligned with what we see in the peer-reviewed literature. In 2019, our likely nursing home resident population is about 60% female, 78% white. The vast majority have a difficulty with independent living, self-care, or ambulation. And so collectively, based on all these descriptive statistics, we conclude that our algorithm is a potentially viable way to distinguish and study people age 55 and older who are imprisoned versus in a nursing home using this data source. And so when we go ahead and start looking at the percent of individuals who report having a disability by people who are incarcerated versus community dwelling older adults, what we see here is that they have higher unadjusted prevalences of disability compared to their community dwelling peers. So again, this is unadjusted. We haven't controlled for anything here, but on average, we find that adults 55 and above who are incarcerated, nearly 40% report having any disability, which is about twice as much as our community dwelling peers. Any cognitive difficulty is really, I think, one of the most striking differences that we see among the incarcerated population compared to community dwelling. But while that's the largest in magnitude, we see that there is a persistent difference across all types of disability examined. Okay. So next, we calculated the average predicted probability, again, for each type of disability for people age 55 and above who are incarcerated versus those who are not incarcerated. And these predicted probabilities come from our logistic regression, again, controlling for age, sex, race, highest level of education, marital status, and census region. And we see that these differences do persist over time. I do want to note at the very top of each of these bars, there actually are these our 95% confidence intervals for our community dwelling population. We had a lot of power and they are just very small and difficult to see at this scale, but they are in there. And so what we find is that compared to community dwelling adults 55 and older in prison are more likely to report cognitive difficulties, that's 15% versus 7%. Ambulatory difficulties, that's about 26% versus 17%. Independent living, it's about 4 percentage points higher for the incarcerated population compared to the community dwelling. For self-care difficulties, it's also about 4 percentage point difference between the two. And all of these findings are statistically significant. So moving on, we wanted to examine how these trends, probabilities changed or did not change over time. And so we observed the predicted probability of having any difficulty. Whoops, excuse me. We observed the predicted probability of having any cognitive difficulty by prison status over time is actually pretty stable over time. We again see that it is significantly higher than our non-imprisoned community dwelling adults after adjusting for demographic characteristics, but we don't see huge swings or changes over time. Excuse me. And when we look at the other disability outcomes, so this is ambulatory difficulties, we generally see the same trend. And this is independent living, again, fairly stable. And self-care difficulties are also fairly stable over time. This was personally surprising to me. I was expecting to see more trends over time, but that is not what the data showed us. We also conducted a lot of sensitivity analyses. I won't go through each and every one of them, but I will say that we did try to really, um, kick the tires on our algorithm, make sure that we really felt confident in what we were doing, that we weren't picking up spurious associations. And so we did apply an additional criteria to our algorithm to identify adults age 55 plus in prison, where we required individuals to report that their current residence is the same as it was last year, so that they hadn't moved or just entered prison. This reduced our sample, of course, but we still found robust results. Individuals who were incarcerated had consistently higher rates of disability, and the magnitude of the predicted probabilities were really quite comparable with what we saw in our primary analyses. We also did multiple analyses where we stratified by age groups because we know, of course, from the broad literature on disability among community dwelling adults that there are, age as the age, of course, we can acquire age-related disabilities. And so we stratify by ages 55 to 64, 65 and above, and 75 or higher. And again, we found our findings were very much what you would expect. As we restricted our sample to be an older cohort, the prevalence of disability increased and the differences between community dwelling and incarcerated adults persisted. And then finally, because the population in prisons might require nursing home level of care, we did rerun all our primary analyses comparing our likely incarcerated population to our likely nursing home resident population. And as you would expect, rates of disability were very high in both groups. Interestingly, it was actually a little bit higher for our incarcerated population than the nursing home residents, which was quite striking. So what can we take away from this? Well, we found that the number of older adults likely in prison has exhibited steady growth over time. It's grown by about 20% if we just look at the growth from 2015 to 2022. But we do find evidence that the growth slowed after the COVID-19 pandemic. Now, that raises a lot of questions about whether or not there's a response issue with the sampling or if the composition of the incarcerated population changed after the COVID-19 pandemic, particularly in light of the high mortality rates that this population experienced. We also find that adults 55 and older who are incarcerated have quite high prevalences of cognitive and functional limitations relative to their community dwelling peers, and that greater age amplifies these differences. We find that this is fairly consistent over time, and that really the cognitive difficulties is where we observe the largest disparity. So there are a couple of policy implications that I think are really important for us to consider. Hopefully by now I've convinced you that this is an important topic to study. It's of growing importance. But as part of making the argument that this is an important topic to study, we really need to have an understanding of the scope of the issue. And identifying and studying disabilities among incarcerated populations is really challenging. This is not something that's currently prioritized or incentivized through policy or reimbursement structures. I think what we've done in this paper and in this work is hopefully a step forward in trying to speak to why this is important for policy. But I think in order to move forward, we really need to have better identification of people with disabilities and more nuanced measures of disability. And I think that policy can play a role in prioritizing that and creating the structures and incentives for us to be able to capture that kind of data. And second, given the existing reality of having this aging population with high levels of disability, building accessibility into the environment in a carceral setting is a really important policy consideration moving forward. And that can involve policy changes to think about accessibility with regards to the built environment, but also social and contextual Relatedly, the striking disparity in cognitive limitations between the incarcerated and community dwelling adults really, I think, motivates the need to develop geriatric informed care models, particularly thinking about de-escalation techniques, um, interdisciplinary care. And because this is a phenomenon and an issue happening on a national scale, I think we really need national policy, or at the very least state level policy, to address the needs of this population. So I've touched on multiple gaps in the evidence kind of throughout my talk today, but just to take a moment, take a step back and summarize the two big gaps that I see are one, measurement related, and the second, evaluation related. So I really talked a lot about measurement today. How do we identify folks? What's the scope of the issue? Um, the current data, as I've talked about, it's sparse, it's irregularly captured. The findings of the study that I presented today are, to the best of my knowledge, the largest study on disability among incarcerated adults. And even then, we're relying on an algorithm that has no measurement error. And so I think that this is a big gap in the literature, and that it would be wonderful to find a way to produce even more rigorous and better evidence. Some of the issues involve proxy reporting. This is a known issue when we're studying disability among community dwelling adults. I think this is really amplified because the survey data that I used, for example, does rely to some degree on proxy reporting, and that can add another layer of measurement error and challenges that we need to consider. The second big gap, I think, in the existing evidence is evaluation based. Right, there's very little causal or implementation research. I mentioned all the way at the very beginning about some novel inventions that various facilities are doing. But we don't actually have a lot of rigorous research to say this is an effective intervention in this setting. This is the cost. These are the returns with regards to patient outcomes, with regards to costs, healthcare use, etc. And so because we don't have a national strategy to support the care needs of people who are aging in prisons, we have prisons, developing their own novel programs. And I noted at the very beginning about some of the hospice programs, for example, and in doing my background research for this project and entering this space, I was so surprised to find that in 1988, the Louisiana State Penitentiary, in Angola actually began the nation's first hospice program in prison. And so since then, it's been adopted by at least 75 other correctional institutions. And again, this is very innovative and creative, but it does raise important questions that I don't think we as a scientific community have fully grappled with yet. What does it mean to have individuals providing incarcerated individuals providing hospice and supportive care to other individuals, making sure that coercion and consent is fully accounted for, as well as the care that the person is receiving is of the quality that they are entitled to, etc. Oh, whoops, excuse me. So where does this leave us? I think there's, as I said, a lot of opportunities for future research. I think standardizing disability measurement, this is something that we grapple with, even beyond the carceral setting, but is particularly important here. And there's just a lot of room for improvement, a lot of opportunities to create more granular measures. It would be perhaps a lofty goal, but having longitudinal studies about aging, cognition, and function in this setting, I think would be really important. And as I've mentioned, doing rigorous evaluation of supportive units, dementia care models, and hospice programs, I think would be really beneficial to the field and to pushing the science here forward. And as is so often the case, of course, whenever we're evaluating these models and thinking about what is the optimal allocation of resources, always remembering to examine inequities by race, gender, and geography so that we can try to minimize unintended consequences of programs and interventions, and make sure that everybody gets the opportunity to benefit from evidence-based interventions. I think also it is important to assess the fiscal and operational implications of different policies to support the aging population. I have not studied as much about compassionate release programs, and so I would really defer to the experts on that topic, but I think that that is something that we will also need to grapple with as our population continues to age and they have high rates of disability. So with that, I think I'm also just about at time. So just to leave you with some final thoughts, older adults in prisons have a substantial burden of disability, and cognitive difficulties is one of the most pronounced differences that we observe. Um, this is an issue that we are facing. So arguably addressing screening, accessibility, care models, and potentially release planning are issues that I would argue that we need to grapple with, and developing a strong body of evidence to help inform these policies is an important path forward. And so with that, thank you so much for your time and attention today. And I'm really curious to hear if anyone's thoughts and questions.
Thank you, Dr. Miller. I was looking at the composition of our audience today, and I'm really curious about their experiences. So, in terms of the study findings that Dr. Miller shared with us, what are you seeing with regards to clients, with regards to individuals that you might serve in correctional settings or nursing homes? Has that changed in the last 10 years or since 2020? What are the health conditions that you see? Anything within that realm? What are your experiences in the field? I'm putting you on the spot. Everyone's quiet. Before her presentation, I was mentioning that we have seen increased institutionalization. We've have seen um, increased rates of individuals with disabilities. So I know you didn't have this data from the data source, and that's part of the measurement model, but to see the reason why they might have been in the correctional setting and how or if that would be related to the disability or if the disability came after. That's the longitudinal piece that you were talking about, correct? That would be interesting.
Yeah, I completely agree. The survey that I was using, unfortunately, does not allow me to disentangle that. I know that some other folks have used the health and retirement study. There is a question about individuals and whether or not they have a history of incarceration. And so there's been some work to look at cognition changes after incarceration compared to individuals who were never incarcerated. Um, excuse me. So I think that that is like one very creative opportunity to use that data source, but it doesn't quite precisely get at what it is that um, you're speaking to, which I think is a very important point. Yes, I can't say anything about reverse causality or anything causal based on this research.
I do know that we being different agencies who provide services for individuals with disabilities, I've noticed an increase in requests to consult, to provide visits, to provide those services in-house. Um, they're not the hospice piece, but the focused on disability assistive technology within these settings has received far more um, attention than I've seen in the last 10 years. So that seems to be a response to this in some way locally. I also wanted to ask you, from a health policy perspective, what changes do you think that, and I know this is several steps down the road, but the fact that you're in this realm is just very exciting. What changes related to compassionate release or accessibility standards? You mentioned that, or Medicaid or post-release coordination. Where within that would you say would we get the most improvement in terms of outcomes?
Yeah, so that's a really great question. And I don't know if we have really the evidence to say one way or another. From just a very like practical applied perspective, um, I would imagine that investing in the built environment would kind of address immediate needs. And we see that, facilities have started doing that. The report that I referenced from 2004 had additional data about how facilities were trying to address accessibility. But I think moving forward, I think dementia will be the big, and cognitive difficulties will be the big issues. So thinking about training for staff of de-escalation techniques, what's the optimal housing solution? I think those are big ones. And then to your point about transitioning, I know that some states are doing some really interesting work to try to help connect individuals with a Medicaid and enroll like immediately upon release, or even trying to get that paperwork done ahead of time. When that's appropriate, I think that, on average, that's a net benefit, and something that evidence would suggest that that is a positive policy solution moving forward. And then to your last, or it was your first point, but I'm going to address it lastly about compassionate release. Um, I I really have not delved as much into the compassionate release. I've been looking at a lot of data about its use, or actually like not as common use, during COVID-19. I think there was a lot of press that made me think like, oh, it's happening a lot more than what the numbers actually show. I haven't delved into that as much because that is such, I think, a sensitive and important topic that I would really need to partner with a bioethicist, thinking about, that question I raised at the beginning: what does it mean to incarcerate somebody who has, like, especially later stages of dementia? What does that mean? I don't know. But then also thinking about what the implications of that compassionate release may be for, the survivors of the crime of why that person is incarcerated, or their family members. I think there's a lot to unpack there, and it requires a lot of really careful thought and really delving into the literature in a way that I have not focused yet. So I think it's very important, but with all those caveats, I'm a little reticent to say too much about what would be the optimal policy solution.
Completely understand. I mean, there's not a lot of work within this area, so appreciate you being in there and trying to get it started. Let's see. I was, you mentioned the policy gaps. Today is election day, and oh, and then we have some comments. Today's election day. To your knowledge, are representatives starting to look at this? Do you see this represented in bills coming through, in policies of any sort at any level?
Yeah, so I actually haven't. What I have been seeing that has kind of raised some flags for me is the privatization of prisons. And I think that that is much more commonplace. But thinking about, how this can intersect with private equity coming into play with like providing medical care um, for these individuals. And I think that there's a lot to keep an eye on and research.
And that would be definitely, we have disability rights representatives on here, developmental disability councils that are focused on that during the season. So we definitely add that to our attention. We do have a couple comments. Faith, if I could ask you, you're introducing yourself as assistive technology. Do you care to come off mic and give a little bit of more context? Let's see. You're still on mute, I think. Oh, trying. We love Zoom. All right. While you're working on that, I'm going to move to Jody and then I'll come back to you. Jody, you made a comment about advocates. Can I ask you to come off mic and give a little bit more about that?
Sure. I don't know if I'm camera ready, but I can talk. Can you hear me okay?
Yes.
Okay.
Yeah.
I switched from my laptop back to my anyway. So we have advocates who do monitoring in the jails and prisons, and I'm sorry, I'm Jody Calsey with Disability Rights of West Virginia, and we have a couple of advocates who regularly monitor some of the jails and prisons. And over time, they've developed relationships with CIMED, which is the mental health provider, and some of the prison staff. and they worked together to develop this desk guide to help guide staff who are working on discharge with individuals with disabilities. So one of the things we see a lot, and what speaks to what you're talking about today, are a lot of people end up needing nursing home placement because they have aged, whether they had a disability when they got there or not, one way or another, they're leaving there with, some pretty significant disabilities, some age, some not. And of course, there's the difficulty of depending on what your charges were, nursing homes won't take you, and there's all that. But you can't get a no for that until you jump through the right hoops. You have to do and Leslie, you probably know more about this than I do. The PASS R, I think is what they call it, for nursing home qualification eligibility. But that's one of the things. And then, getting Social Security benefits started back up if somebody was already on, getting, like somebody mentioned earlier, Medicaid. Um, Housing, all the different things. West Virginia has a pretty strong reentry, uh, whatever you want to call it. I don't even know what you want to call it, but there are reentry councils throughout the state, and they're kind of organized statewide through Council of Churches, is who I think initially got the funding for that. And then they hooked in with Division of Corrections and Rehabilitation, and now there are reentry counselors built into the prisons. They're part of, the staff in the prisons. So our staff's been working pretty closely with a couple of the prisons. And then I mentioned earlier in my when I typed a message that St. Mary's Correctional Center has a dementia unit. They may have two, I'm not sure, but I know for sure that they have one dementia unit. And they do use fellow inmates to do some of the services.
Interesting.
Yeah.
So interesting. Thank you so much for sharing and for incredible work, especially about the desk guide. That's really interesting.
I mean, I was so proud of our advocates when they did that. I can't take any credit for it. I had nothing to do with it, but they did a great job. And I actually used to work in that world. I worked in jail many, many years ago.
And that's powerful to have people who know both perspectives.
Hmm.
That's what we need.
Yeah.
Thank you, Jody.
Hmm.
Faith, I saw you left us and came back. Do you want to try it again?
Yes, can you guys hear me?
Yes.
Perfect. Yes, I did hear the tail end of that, and that's amazing. So basically, I am an assistive technology specialist. Um, we manage a lending library of assistive tech, which simply put means any device that can help someone with a disability complete a task. And so that's a wide range of devices, and every state has an AT program. So ours is called WIVATS. We are at the Center for Excellence in Disabilities. So any of you guys on this call, please feel free to reach out if you need assistance with clients or if you have any questions yourself. Um, but yeah, I had put in the chat that I attended a training recently that had said the average age of depression is increasing because the aging population is becoming more depressed, and I think that was something very very interesting and surprising. But I really wanted to attend this um, sorry, I haven't had enough coffee today. I really wanted to attend this session today because I really think that there should be more research in this area, and I'm really happy that there is being reviews done for this, because I think the aging population is kind of forgotten, but especially when it comes to correctional facilities. And so my mind is just going crazy with ideas of how we can kind of extend our help in this area too, just with the services that we provide. But yes, just kind of an overview of what we offer from our end. But again, thank you so much for presenting this. This was very informational, and yeah, it just gets me thinking. So thank you so much.
Thank you so much. It's really helpful to hear more about um, your work, and it's interesting to hear you talk about the uh, increasing prevalence of depression and One thing that I haven't touched on, but I think are starting to get at is, of course, mental health outcomes are so important in and of themselves, but we also know, of course, right, the relationship between physical health and mental health. And so thinking about that angle moving forward too would be important. Thank you.
Wonderful. Thank you, Jody and Faith. You all need to connect. I think you could make great strides together knowing that system. That's great. Any other questions before we leave? We're about 5 minutes before the hour. All right. Well, Dr. Miller, I appreciate you joining us on a pivotal day for our next steps, policy-wise, and on this important area. I'd love to bring you back for your other areas of study. They sound fabulous and pertinent to the work in West Virginia. For everyone who joined us today, if you, I did put the link to the evaluation. We love to get feedback. We share that feedback with Dr. Miller and all of our presenters. Everyone wants to know how we can make it stronger, right? And more pertinent to you if you spend the hour with us. So please fill that out if you can. And with that, then I hope everyone has a great day, enjoys nice weather. And again, Dr. Miller, thank you for joining us.
Thank you so much for the opportunity. This was wonderful.
Absolutely. Take care, everyone. Appreciate it.
Bye.